My name is Constant Mouton. I am South African living in the Netherlands. I worked for a company called Triora. We are also a sponsor. You'll see things all around from us. It's wonderful to be here again as part of the iCAAD family. We presented, let's talk louder, closer, okay. That good? Okay, yeah, I always have a problem with this, so just shout if it's not good. It's wonderful to be with iCAAD again. We were at the London event as well, and it was wonderful. So it's a pleasure being here today. My topic is the elephant in the room, talking about comorbidity. And luckily it coincides with the presentation of Christophe. So let's get starting. I have nothing to disclose, unfortunately. Outline. What I will do today is we will talk about definitions and terminology. I think that might be the first elephant in the room, is that we don't use the same language. Then I will move on a little bit to the epidemiology, like how big is this elephant? Is there really an elephant, or are we exaggerating here today? We will talk about why it happens, a little bit about the chicken and egg story. Then I want to look at what happens if we don't treat the dual disorders or the dual diagnosis. I will share with you a little bit about how we can treat it and what we know about that, and outcomes if it is treated. You'll see in my presentation, I use the example of, I have a case summary that will come back about 5 or 6 times. It's a real case from the clinic that I've anonymized, and the case is on ADHD, then you know what the diagnosis will be in the end, but the reason is we do research on ADHD and addiction, and we treat quite a lot of it, and Christophe whispered in my ear that we need to talk about ADHD a little bit, so I'll use ADHD as the example of a comorbidity. So, I'm still on. So to start off with the definition, the first term is dual disorder. It's also called dual diagnosis, if you want. And it implies a mental illness and a substance abuse occurring together in the same person. Now, already in the first term, you will see, I said also dual disorder, dual diagnosis. Some countries, they say double diagnosis, double disorder. Within the definition itself, there's a problem already. There's a few problems. The first one is a mental illness and substance abuse. So they talk about substance abuse, they don't talk about addiction. So they're forgetting the other addictions, the behavioral addictions. The next problem I have with this definition is that they imply that mental illness is different from addiction, as if addiction does not occur in the brain. It's not a brain disorder. So maybe there's also something not completely right. Comorbidity is a little bit more appropriate maybe because it's two co-occurring disorders in the same person. But then you don't have the other stuff. Christophe already spoke about family, about relationship problems, there's so much happening, so we're also not recognizing within the definition itself how complex this is. I think it was years ago we all thought that, we're treating addiction and the patient only is addicted, but that's not true, unfortunately. There's so much playing in these patients. So I don't have the answer to a new definition. I have a suggestion, though. I would say that something about comorbidity of addiction and another mental illness with psychosocial issues, something in that direction is maybe a little bit more correct. But in the end, dual disorder is a well-known definition, so I will stick to that as well, and I think we all know about it, and all the research is on that definition as it is. So for the case of, mine is just running through. I don't know why this is happening, so let's go to the case anyway. Let's continue with the case of Mrs. X. She was treated in our clinic. She is a 29-year-old Asian female, university student, residing in The Hague. She presented with suicidal thoughts. She told me that she didn't want to live past 36. She was 29 at the age, so not acute suicidal thoughts. And the reason why she didn't want to live with the life that she's living at this stage. How was this life? This life was known with a labile mood, all sorts of ups and downs, not sleeping well, not concentrating well, being distractible, very emotional. She had panic attacks when she had to do exams, and she used alcohol daily to calm her nerves, as she said, and she ate coffee. And I'll get a little bit to that. She used to drink coffee in the morning before she went to class. She used to drink coffee just to wake up and to be present. But that wasn't enough. So in the end, she ate spoons of coffee to go to the first lecture. Then after the first lecture, she would pop right back home and drink 2 glasses of wine to calm the nerves down because she would become panicky from all the coffee. And so she would proceed during the day. She didn't see it as an addiction problem. It was just a way of managing her symptoms, really. She diagnosed herself with borderline personality disorder because she was suicidal. Obviously, she must have had that, according to her. She had a panic disorder and depression, and if I could help her, please. So that's just for you to keep in mind. Mrs. X will come back in a while. So the epidemiology, what are we talking about? Is it really that big a problem? Yes. The numbers are also, I was happy that Christoph also referred to it. It depends on who you ask, really. There is so much research out there, and because the definition is not an agreed upon definition, you get different researchers. But anyway, lifetime prevalence of any mental illness is 42.7%. So 42.7% of us will deal with a mental illness somewhere along life. I don't know why this is running through. Anyway. The prevalence of any substance-related disorders is about 20%. Mood disorders, anxiety disorders, 20%. Lifetime prevalence is 9.2%. Depends on who you ask, and whether it's in children, adolescents, or adults. I have another slide on that. Lifetime prevalence of substance use disorder, not all addiction, only substance addiction, in severe mental illness is 40 to 60%. So more than 50% in the States is the number that they use. Patients in addiction care units with a mental illness. So if you work in a in an addiction unit, then probably 60 to 80% of your patients will have some sort of mental illness, whether that be severe or not that severe, but something. Just a few interesting numbers. If you talk about schizophrenics with substance use disorder, it's about 47%. In a group of bipolar patients with substance, it's about 50 again. Depressions, around 25%. ADHD, around 25% actually. This is a low number. Anxiety with substance, about 25 again. PTSD, a lot of post-traumatic stress disorder. We kind of forget that the patients with addiction, there's a lot of trauma involved. And this is severe trauma if it's post-traumatic stress disorder, but if you take the little traumas in life, it's even more. And personality disorder, we know that about 44% of people with borderline personality disorder has alcohol problems. So as you could see in the epidemiology already, almost all studies are done on substance addiction. So I found one interesting slide about a behavioral addiction. So the lifetime prevalence of any psychiatric disorder in a group of patients with pathological gambling disorder is 97%. That's really enormous. Alcohol disorder, 75, drug use, 14. Personality disorders, more than 60% of personality disorder in people who are addicted to gambling. Quite alarming numbers, these. Mood disorders, around 50%, and anxiety, more than 40%. Quite alarming. Just to focus on ADHD and substance use disorder, the last two little bulbs there, the first one is the prevalence of substance use disorder in adults with ADHD. So if you treat ADHD, around 28% of your patients, of adult patients, will have an addiction problem as well. If you work with substance use disorders or addiction, around 23% of your patients will have ADHD. Just to show that interaction there. So let's continue with Mrs. X. Oop. So we had a second consultation after the first very elaborate one, and we drew up a timeline. So this is one of the first little things that I want to show you, is that you can do a timeline to fit everything together and to see what happened when. That gives you a good clue. So in the early childhood, already she had feelings of insecurity, poor attachment to her parents, and she often felt depressed and actually lonely. It was more a feeling of loneliness. Later in life, she realized that even though she was academically strong, she struggled to complete tasks. She was always late, and she only performed well when she was really under pressure. Then she would do things. Then she was also academically very strong, so kind of things evened out at some stage. So after many failures, she started to become more and more anxious, and she developed a panic disorder, or panic attacks. And in the end, she even had fear of fear itself, so she had like an anxiety problem as well. It was only when she got to university at about a year, I think she was 18 years old, when she started to realize that she can augment this behavior with the coffee and the wine, the way I told you, and that developed. And at that stage, things just kind of got out of control because she was busy with her master's degree in architecture for about 8 years. And she thought, I have to do something about this. So as Christoph said, why does it happen? It's really a question of chicken or egg. We'll see. Maybe I don't have an answer. So there are a few different theories on this. The first one would be a primary mental illness with addiction. So there are different theories on this, but think of a patient with schizophrenia. Schizophrenia is known by negative symptoms, the negative symptoms being the stiffness, the fact that you can't smile, that you're not out there. And then you use nicotine. The reason why schizophrenics smoke that much is because it softens all these symptoms. The same with the medication that we prescribed for the schizophrenic patients. It also slows everything down. We talk about the extrapyramidal side effects. And nicotine has a positive influence on that. So the fact that so many schizophrenic patients smoke is not that strange, actually. If you think of other ways, Christoph touched on it already. Panic disorder, for example. If you have a panic disorder, you might realize that drinking calms your nerves. That might lead to more impulsivity if you are under the influence of alcohol, which might lead to other addictions again. Or a manic patient might abuse substances because they are more impulsive as it is from the mania. A last one, prescribing addictive medicine might trigger the addiction. So this is a big controversy with ADHD medication. If I prescribe stimulants to my patient, will my patient become an addict later in life? The answer is no. There are more than 10 studies to prove that this will not happen. The contrary will happen if you don't treat the ADHD in childhood. The chances are between 60 and 70% that a patient with ADHD untreated will develop an addiction. So that's not true, but what is true is if you prescribe high doses of steroids, for example, for asthma, you might elicit symptoms of a mental illness being a psychosis. So that could happen. Second part of the theory, other way around. So you have an addiction, and the addiction might elicit psychiatric symptoms. For example, intoxication. If you think of LSD, you will hallucinate. Hallucination is a psychiatric symptom that can happen. Substance use might unmask underlying mental illness. Now, this is an important one because there's no research to show that a substance in itself can elicit or cause mental illness. That's never been proven. What has been proven is that if you are underlying prone to, let's say, psychosis, and you use too much cannabis, you can initiate the first episode of the psychotic disorder. That has been proven. And then, of course, substance use can worsen the existing mental illness. That's also vice versa. That's also true. We'll get to that just now. So a very important distinction I find to make here. Next theory is that it might just be two dual disorders that has nothing to do with each other. Somebody might have a personality disorder and become gambling addicted along the line, just as anybody else can become gambling addicted. That might also happen. Or they can have common etiologies. So think of, my favorite one is with ADHD. ADHD and addiction have similar genetic underlying factors. I'll show you just a slide about that now as well. Or think of biopsychosocial factors like family dysfunction with conduct disorder leading to an addiction. So things can kind of like be a melting pot of things happening together. So the general concepts of these theories are that in your patient you might find one, several, or none of the above reasons. That's all fine. It's just think of it of a way, of a direction to think when you are looking for chicken or egg, what happened when. People with dual disorders get addicted for exactly the same reason as the rest of people. Experimental use, to feel good. Think of people going to a club on a Friday night and using drugs. But important in dual disorders, to feel better or to do better. I don't know why everything is running on its own. And then important, just want to bring that point across again, the timeline is really essential. So the first thing to keep in mind is having a timeline. So moving back to ADHD, I found this a funny slide for you to just make it interesting again, to just remember how ADHD feels like. So just with everything that you know now, let's look at why people with ADHD get addicted. So the first one would be associated disorders, depression, anxiety, PTSD, sleep disorders, all these things happen more often in ADHD. So that can lead to addiction. Genetic risk, that like I just said, novelty-seeking behavior may predispose an individual to both ADHD and substance abuse. Impulsivity is a core symptom of both disorders. Aggressive behavior, conduct disorder, more frequently found in ADHD, leads to addiction. Stress, high cortisol. People with ADHD has more stress because of the adversity, which is 0.6, which leads to loneliness, failures, dysfunctioning. Unemployment is higher in people with ADHD. That in itself can lead to an addiction. Relationship problems, also higher in untreated ADHD, can also lead to addiction. Or multiple traumatic brain injury, that's an interesting one. These little guys with ADHD, they run, they fall, they bump their heads, they don't have a stroke or a big hemorrhage in the brain, but small little injuries, and that's also been shown to cause addiction or to lead to addiction. So let's continue with Mrs. X. So she also had all these failures. I mean, the academic failure was the biggest one, still being busy with her master's after 8 years and not succeeding in anything. So we completed a genogram. I think that Christoph also touched on that. I think in my timing. We completed a genogram, and just to see how the family is also involved. And then she realized, when talking, so what I do is I do the whole genogram, and I go and I focus on specific people in the genogram. And she realized that her father also had similar problems, also ADHD actually, undiagnosed, and he was 67. He became described as a hard, strict man, not showing any emotion, so he was emotionally unavailable. And her mother was also emotionally unavailable. She was very labile, crying all the time, and not really emotionally available to her children. So Mrs. X learned at an early stage to fend for herself, which would become quite handy later in life because she had to in the end. Having all these failures, not getting the proper medical advice. She's been to many psychologists, psychiatrists, colleagues before with her own diagnoses, and then she gets the wrong therapies or just little bits and pieces of therapies, but never a comprehensive approach. So let's look at what happens if we don't treat dual disorder. Obviously, it has a negative impact on treatment, otherwise we wouldn't be talking about it. But what happens? So like I said, addiction in predicts a worse outcome for mental illness, and mental illness predicts a worse outcome for addiction. So we have a dilemma here. We have it happening in about 60 to 80% of our treatment centers, and it predicts worse outcome. Non-response or poor response to treatment is more associated with dual disorders, also more frequently non-compliance. Increase in hospital admission rates, so it's increasing the overall health costs, and increased suicidality rates in this group. It has a negative effect on psychosocial functioning, and with that I mean higher rate of homelessness, unemployment, more family problems, and more legal problems. People with dual disorder end up in jail more likely. Medical problems, they have higher rates of HIV, hepatitis, and sexually transmitted diseases, also a higher mortality rate. They receive poor health services, and this is a very important one for us sitting here. I think in this room it's quite safe to talk about it, but out there in general hospitals it's a completely different story. More stigma within the health sector. I think everybody's heard the stories of, if you're working in an addiction unit, someone's like, that one just has mental problems, that's completely useless, that's never going to work. Or in mental illness, but that one is so addicted, we're never going to be able to treat the depression. So people kind of give up on their patients. There are less qualified staff and treatment facilities to treat both these disorders, or this all these complexity of disorders. And they have more problems getting care and treatment because of all these reasons. So let's look at Mrs. X again. So after the comprehensive psychiatric assessment and the screening for common occurring comorbidities, we had to make some diagnoses to know where we're going. So we made the diagnosis of ADHD combined type, alcohol use disorder, problems within the family, and most likely an attachment disorder as a child. But we were left with a lot of other symptoms: the panic disorder, the hopelessness, the anxiety, the suicidal ideas later in life, all of that. And we decided that these could also all be linked back to the ADHD, most likely. So we left that out of the diagnosis for this stage. And we decided to first focus on this and see what happens. So the next question would be, how do we piece all these pieces of the puzzle together? So the first point is to do a biographical assessment. So do the timeline, look at everything that happened in the different phases of life. If you can get a collateral history, it's also good to look at, to ask the parents and the family, how were they as a child? I start even before the patient was born. How was the pregnancy? You can really start there with really knowing all the little bits and pieces as it happened. Look at the quality of life factors, all the different life domains, very important to take into account. Screening tools. We use screening tools in our clinic, and I'll show you a little bit later on exactly how we put the pieces of the puzzle together as an example. But screening tools are only helpful. They are not diagnostic, so they might point you in a direction, but please don't use them for diagnosis. That's not what they're made for. Do a proper addiction history, and on this, it's going also, it has a life of its own today. Do a proper addiction history, and with that I mean look at the substance addiction, but all the other addictions. Ask for it. You know, if you don't ask if somebody is addicted to porn, they're probably not going to tell you if they come for their ADHD, but you have to ask for it. Do a proper psychiatric history, proper medical history. Ask for all these things. Ask for sexually transmitted diseases. People don't want to talk about it, but if you ask, then you will probably get some more information. Trauma history. Look at the physical as well as the emotional trauma. And we tend to look in psychiatry as psychiatrists for the big traumas, you know, the life-threatening situations that might give post-traumatic stress disorder, but also look for the little traumas, you know, being bullied in school, those kind of things. Ask for it. And if you do the biographical assessment, it kind of fits into your story and your questioning anyway. Psychological issues like self-esteem, we also tend to overlook. And get the big picture. I'll show you a few slides now of ways to get the big picture on a piece of paper for your patients as well. And this is the first one. So the first one is to look biopsychosocially, and actually the biopsychosocial approach could also have religious and spiritual and cultural, and you can really expand on this, but okay, we use the biopsychosocial. What I've done here is in purple are the factors of Mrs. X. But these are some of the common things that you see. Genetic predispositions, physical development, intelligence, temperament, psychologically, looking at personality structure as well. That kind of also, when you do the biographical assessment, you also pick up these things about the personality. Defense mechanisms, response to stresses, trauma, coping strategies. Look at peer relationships. Like, does your patient have friends? How do they interact with others? How are their relationships? Ethnic influences. I've met people from at least 6 different countries this morning, just before talking today. So remember the ethnic influences on all of us. Immigration is traumatic in itself. Socioeconomic influences and religion. So this is one way, and what I do is I literally draw this for a patient, and we fill it in together as we go along to give them an idea of, okay, this is actually what's happening. Another way would be to use the dynamic approach. So firstly, make a list of all the problems or the diagnoses. And here you can put in diagnoses. You can imagine with Mrs. X, it would not be possible to do this in the first session because then you have a list this big. So you have to narrow it down a little bit and focus on specific things. Like we focused on the ADHD, the alcohol addiction, and the family problems in the beginning. Just those 3 things. Those were the problems. Then the next step would be, what predisposed me to this? And what makes me vulnerable to develop addiction or depression? You can also use this for psychiatry, for anything. What made me vulnerable in the first place for this to happen? Is it genetic? Is it my family environment? Was I adopted? Think of those things. The next thing is, what makes you come to your counselor or your psychiatrist or your psychologist at this point in time? So what makes you sit in front of me now? So what triggered the most recent episode? Then when you're this far, the next step would be to look at the perpetuating factors. So what makes that I keep on coming back and I keep from recovery and I'm not getting into recovery? So what are the factors that makes me relapse the whole time? And these might be different to the precipitating. They might be the same as well, but then at least you know and you have kind of scheme. And the last one is a more positive one because these are all about the problems and how that works. And the last one is what's protective. So what are my resilience factors, if you want? So what keeps me safe? What makes me strong? And you can use this, for example, by using the genogram. For those of you who are ARISE trained, I'm seeing some ARISE colleagues here. You can use the genogram to get to resilience factors, or you can just use a family story to get to resilience factors. But it's important for a patient to see this on paper, that it's not all a big drama, you know. I can get out of this, because part of treating these patients is giving hope. And there's also something that we forget, is if we don't give hope, then why are we doing this, you know? So this helps you to put things into a bit more of a protective schema for them. So now you've got the big picture, but not all patients are the same. So what do? You've heard me saying that we need to treat all these patients, but how do we do that? So this is an interesting graph. So you'll see at the bottom mental illness from being not severe to very severe, and on the side addiction not severe to very severe. So if you look at number A, it's severe mental illness, but the addiction is not that bad. So let's say somebody with a chronic relapsing schizophrenia, being addicted to cigarettes, smokes a pack per day. The dot B is completely different. There, the addiction is very severe. Think of somebody that uses heroin every day, but only has an adjustment disorder, or a bereavement. So the mental illness is not that heavy, but the addiction is much heavier. Number C, everything is there. There's like severe addiction, severe mental illness. So you can imagine that different patients need different solutions. Which brings us to the next point, and that's the difficult part of this, is the treatment models. So the treatment models, the first one was the original one that we all were taught in medical school, at least, looking at the psychiatrist in the room, is that you first treat the substance abuse, then you treat the mood disorder, then the anxiety. Maybe you'll get to the ADHD. Actually, in the time I was trained, ADHD in adults never existed, so that was a disorder of childhood. And then really, if you're a very good doctor and a counselor, you will get to nicotine abuse and try to treat that as well. In children, just go back into this, in children usually we start by treating the ADHD, and some of these adolescents might smoke, but nobody talks about the mood disorder or the anxiety disorder, and we forget about the addiction in children. I'm very happy to hear that we're going to talk about that this afternoon in children and adults. I gave a talk about ADHD and addiction in South Africa, and people were shocked to hear the ages in Europe that people start using drugs. And I kind of spoiled it for them and said, it's probably the same in South Africa. You're not special here, so people start using quite early. Okay, but this is called the sequential treatment model. This doesn't work, because while you're treating the anxiety disorder, the substance disorder is relapsing already, which has a negative outcome on your anxiety disorder, and you'll never get to the ADHD, so this doesn't work. The outcomes of this is actually about 1 to 3% abstinence or remission for the mental illness a year. So really bad plan this. What's better is to treat everything together. My slide is not completely correct, because I also say that you treat ADHD and then the anxiety and then the mood, but the point here is you treat the addiction and the mental disorder at the same time. There are two ways to do this. In a lot of countries, this is done by separate teams. So you have a psychiatric team and you have an addiction team. That gives a little bit better outcomes, about 10% or so, I think, off the top of my head. What works better, then you get to the 26%, is to do integrated dual disorder treatment. So the same team, same location, same time, you do everything together. So this is the most effective way of treating. But now you might ask, but where do I find a team that's capable of doing this? Well, that's the trick. That's what we have to do as treatment providers, is to build those teams and to give these treatments. What you need for a team like this is a multidisciplinary team. The more disciplines you have, the better the outcome. Stage-wise interventions. So I'm just going to go to the next slide. And this is on purpose. So these are, Christoph also referred to this, the cycle of change. I think everybody here might know this already. So if you work with the stages of change, a patient might be in pre-contemplation, contemplating going treatment, or they're contemplating, but then they still need to go to preparation. What Christoph also was getting at is you have to talk to patients at the point where they are and motivate them to get to the next step. You can't expect somebody from contemplation to go directly into total abstinence from everything. Then it's a disaster. People will not come back, and they'll continue using and think, the psychiatrist is really crazy, I'm not doing this. So that doesn't work. Different ways to use that. To do that, you have motivational interventions, motivational, what do you call it? Interviewing. I'm thinking in Dutch. Invitational intervention is the ARISE method. That's slightly different. We also use the family then to push the patient into the next cycle. Interventionists also use this a lot. You need substance abuse counseling, group treatment, family participation. You really need comprehensive services. That's an interesting point, and that's why I like iCAAD, because we can find each other here. For example, our treatment facility, we don't do the detox, for example, and we don't do residential, but we have partners that help us with that. So the patient is still getting the care that they need. If your team can't do it on their own, you can rent other people or find other people to help you with that. Participation in alcohol and self-help groups, pharmacological treatment interventions to promote health, and secondary interventions for treatment of non-responders, also very important. So a lot of things needed to do this. So how do we do it in our clinic in Treora? I'll show you, we have kind of a stepped approach to this, but it is integrated. So after the detox, which we don't do ourselves, we do outpatient detox, but the inpatient detox is done by another company. So on the first day of admission, people get questionnaires, they have a history, they see the doctor, they see the counselors, they get integrated into the program, and we take the first week to evaluate the patient. It's not necessary to do it in one sitting. We're all trained to do it in 1 hour, to sit with the patient and know everything. That's not going to happen. So use different sessions to learn more about your patient. And also your treatment plan doesn't have to be fixed on the first date. You can also change as you go along. I saw a nice interview that Neil did this week on changing, people at the cabin telling us about changing the plan as you go along. It's also a very good plan. So then we start with the treatment of the substance use disorder, or the addiction, I should have said here. And if a patient does have ADHD, we start treatment around the second week. We start the treatment. So this is the first part of the treatment. So this is the medication treatment that we start then. Also, they join the ADHD group. So the ADHD group is a psychoeducation group, but it's also a group to support each other, and that continues throughout the treatment. So while they're doing the substance use treatment, the ADHD treatment, they're also going to ADHD group, and we look at the rest. Is there still depression or other stuff that comes up in the treatment? As you start to get to know the patient, you might know other things. Weekly follow-ups, very important. Also to follow, we do checklists every week then, to follow the patient through and to see if they improved over time as well. And luckily with ADHD, it's very, very nice to treat actually, because you see the results almost immediately. So let's see what happened to Mrs. X. So after 6 weeks in treatment for the addiction and for ADHD, she was experiencing rest and focus. She even got feedback from the therapy group that she's much more calm and they like working with her. She engaged in 12 steps meetings as well as the ADHD support group. At university, she was able to focus on her research again. She had no panic attacks or anxiety anymore. We didn't do anything to treat that. Nothing whatsoever, it was just gone. All the borderline thoughts were gone, no suicidal thoughts anymore. She wanted to have a long life because she didn't have the life that she had at that stage. So also with personality disorders, be careful of diagnosing that right in the beginning, because it's probably not true. You know, when you get admitted for addiction, you're not the best version of yourself, so we kind of forget that. So we should watch out for pathologizing things as well. And she experienced hope for the future and connectedness to the fellows, which is a very important fact that we should also not forget. So what happens if we do treat patients with dual disorders? Well, you can guess a little bit. They have high rates of stable remission, reduced psychiatric symptoms and suicide, shorter and less frequent admissions. So for people working in government settings, it's cheaper as well. Decreased utilization of resources, improved vocational functioning, fewer arrests, less violence and victimization. So the stigma also decreases for these patients. They have improved overall physical well-being, better relationships with families and others, and overall life satisfaction improves. So if you ask patients what helped them, This is interesting because I have 2 articles. The first one is this research group from 2000, it is. Stable housing, they said, helped them. Sober support network or family support network. Regular meaningful activities. Going to work, for example, can be meaningful. Helping others can be meaningful. Trusting clinical relationship with the clinician. These are the 4 things. In 2000 already this research was done. Then a team from Belgium published an article in July of this year where they reviewed this finding. And the first thing was being connected. This is what patients found helped them to stay in recovery. So feeling supported by family, peers, others, and able to participate in the community. That kept them safe. The next thing was individualized treatment and shared decision making. I don't know where you are working, how it works, but I've seen treatment facilities where the counselor will tell the patient, this is what you have to do, or otherwise this and that will happen to you. And there's no shared decision making. But that really helped patients. Next one was spirituality, so having personal beliefs, such as fostering feelings of hope, once again, a sense of identity, gaining ownership of your life, and finding support in spirituality helped them. And the last one was meaningfulness, or sense of meaningful activity. So importance of meaningful activities that structured one's life and give you the motivation to carry on. So once again, that element of hope is also there again. So my last slide, and I'll conclude with this, is that common things occur commonly. This is a common thing, dual disorders. It does occur commonly, so don't miss it. It is an elephant in the room. I think we can agree on that. And if you ask for it, you will find it. Diagnosing is a complicated art, but it's not impossible, as long as you have a certain way of doing it. And there's no wrong way or right way. There are different ways to get to the point where you have the diagnosis, but it is possible. Don't forget the timeline, the biography, and the formulation. Integrated treatment gives the best outcomes. And next to the medical and the psychiatric and the psychological things, it also helps to have a spiritual component to treatment. It helps to work on the connectedness, the family, the society, even the support groups can be a connection, sponsors can be a connection, and meaningful activities. Don't forget to involve the family and the network. Some people even say that addiction is a biological disorder, but it's also a disorder of the family, because it does happen within the family. So without the family, you also have poor outcomes. And help patients understand their own history and their own story. And those little diagrams that I've used are very, very helpful to patients to understand what's happening. So if you use the genogram, the dynamic approach, and the biopsychosocial factors, then a patient has 3 pages. And in 3 pages, they can kind of have a deeper understanding of who they are and where they're coming from. And that really helps them and give patients hope. That's my last point that I want to give you. So I'll conclude with that. And then I think we still have some time for questions or comments, or we would like to learn from you as well, to hear what you're doing. But this is my part anyway. Are there any questions, any comments? Everybody's hungry, wants to go to lunch. And yes.
Thank you. That was a very well put together presentation, and a joy to hear. So it's nice to see you offering a lot of hope to patients who are coming in. My question was, we're talking about ADHD and comorbidity. Do you also sometimes see that there can be ADHD and also giftedness?
Yes, absolutely. Yeah. I mean, this lady as well,
yeah.
She was very gifted. And actually her intelligence, it was a protective factor, but it was also a causative factor. Because she was intelligent, she also took chances of not writing exams, because she knew that if she put her head to it, she would make up later with another exam. So it can work both ways, but definitely we see that a lot. Yes.
Okay, thank you.
Yes, you're welcome. Any other questions, comments? Clear? The slides will be available, I guess, so don't worry about that. Or if you want a copy, just send me an email. And I think, shall we take a break, or do you want to still... You have a question.
Don't mind.
Not at all.
I have a question. Oh yeah, you need that one, yeah. Alors je vais poser la question en français. Okay. So yes, I asked the question in English, so translation will be consistent. Okay. Um, the I'm going to go into the ADHD, and do you see differences between what we call ADHD, what we call ADD, what we call hypervigilance, and are there different ways to address that? Because there's a bit of a general cluster around the hyperactivity. I have worked a lot with people with huge hypervigilance acquired from probably childhood, very stressing, permanent experience, little teeth on a daily basis becoming a trait. So do you have something to say about subscales around the family of the attention deficit disorders?
Yeah, there's an interesting diagram. It's called ADHD and Friends. And then you see quite nicely how the overlap between things. Like ADHD rarely occurs on its own. But then also if you look at the clusters of symptoms, like in itself, impulsivity is also a symptom of both addiction, conduct disorder, for example, and ADHD. So you have to look at those little symptom clusters if you want. What helps me in the diagnosis of putting these puzzle pieces together is to use the biography to see what happened when in time and what the effects of it is on their lives. And then you can get to a point where you can cluster things together, but sometimes you don't get to that point that you can cluster it together. You just don't know enough about the history, and those are difficult patients to treat. Those are really where you struggle. I guess there's no real screening list or diagnostic tool that you can use. It comes with experience as well. And sometimes you just have to make 2 or more appointments 2 or 3 extra appointments with the patient to get to the point where you've really, really sussed things out and know what is part of what, really. More on a practical level. I mean, on an academic level, I'm not sure how much research has been done to suss these things. I mean, there's also a big discussion going on. If some physicians say that if somebody's a bit hyperactive and is impulsive and addicted, then you don't have to do the diagnosis. Just treat with stimulants, and it will be fine. I would not advise that. I mean, you have to be clear about your diagnosis and what you're doing and what you're treating, because there are still risks treating things if you don't know what they are. So if you don't know what they are, don't treat them, until you know what they are, or refer. I mean, you don't have to know everything yourself. It's complicated.
Hello. Yes, thank you very much for your talk. I'm Philippe Cavaros. I'm a psychologist with the Promise Group. I coordinate the French program there. And what? Okay, I am better. A part of the meds, what works best with ADHD people? Groups? Can you elaborate on that?
Yeah. So there are different things. Like I said, the ADHD group for us is very helpful. And that's in different ways, because what we do is we do a lot of psychoeducation in those groups. We teach patients different ways of structuring themselves, like having a day structure, having some quiet time, using things like yoga and meditation to wind down, all those kind of things we teach them in those groups. And there's also a sense of support from other people with ADHD, and they teach each other as well what works for me. So that kind of helps. I mean, if you look at the guidelines for ADHD, medication is still the main treatment for it. So that we do treat with medication. But some people also refuse to have treatment. They refuse to have medicine, and then we give them the other tips and tricks. We also get the family involved, because if there's more of an understanding within the family, this is also just for psychoeducation really, if there's more of an understanding within the family and the support network, even the employers sometimes, then you can also structure the day differently, or you can build in little moments of rest. Like this Mrs. X, for example, she slept quite a lot. You would think that she's very hyperactive, but by 7 o'clock at night, she was completely out because she had so many impulses that she had to filter, that she was dead tired in the evening, and people thought she was lazy. And then if you explain that this is not laziness, but she needs more sleep because she has so much more to filter in a day, that also works. So that's kind of what we do. I don't know if anybody else has more tips or tricks.
I'd just like to add a little bit to that, because sometimes with ADHD you can also have fine motor coordination or problems. So when she's getting overtired, it could be that she has a sensory integration issue where she likes tight stimulation or things. So there could be, within the diagnosis of ADHD, also the occupational therapists that could help support some of the extra, the hypervigilance and other things by giving some extra, yeah. So that might help. And then I was also wondering whether with the hypervigilance, there's a little bit of shame going on. So I have to be hypervigilant to look to see for the what people are thinking about me. And maybe helping with that also helps reduce some of the symptoms.
Absolutely. The shame is actually interesting that you talk about shame, because it works from different ways. I mean, you have the shame from being addicted already. I mean, that's in addiction care, that's already a topic that we have to talk about. But then in ADHD, there's a double shame, because from this small, you've been told that you are naughty and you are stupid and you're impossible and what do we have to do with you, and you're such a horrible child, and your sister is much more calm than you, and she, you know. So there's shame, and then there's also from the hypervigilance of. So it kind of escalates as well. So that's something we would address in individual therapy. We talk about shame a lot. Yes, yeah, good point. Thank you.
I have another question. What you presented here is a residential model mainly. How do you see things when sadly, you know, residential is not possible or not affordable? Is all this possible in day programs, in you know, even with frequent sessions? How do you see that? Or is that impossible?
No, it's not impossible. Never say never. Come on. Yes, come on. No, never say never. I mean, we also have an outpatient program where we also treat it in a similar fashion. I think if you want to treat somebody in an outpatient setting, you have to rely on the family a lot and the colleagues and involve the network once again. Or as I've outlined in that quadrants of Minkoff, it's called, with the severity of the addiction and severity of the mental illness, you can also play around within those quadrants with what a patient can do. I mean, if a patient has mild ADHD with mild addiction, there's no risk in it, I guess, to treat in an outpatient setting. I mean, we look quite critically at whether inpatient is the only way, and of course it's the best way. I guess it's the easiest way in many ways, but we're quite critical in looking who can be treated as an outpatient, as an inpatient. But I don't think it's impossible. I think with regular follow-ups, good support network, I think it's absolutely possible. Yeah, most people with ADHD get treated as an outpatient anyway. So, and I guess addiction as well, you could also treat as an outpatient. That's not a problem. No. Any more questions? Comments? One comment here in front.
Hello, my name is Angela Harn. I'm an art psychotherapist with an educational background. And one of the problems we have is, or had, and there's research to support this, and I'm just wondering, is there a change in terms of ADHD students, is that for the first year they did very well on medication. But then it started to slide after that. And I'm wondering if there's been change in medication, if there's better medication, or what's your feeling on that?
I don't know anything about that slide after a year, but I think the
first year, possibly two, and then after that it stops being effective. And this is for primary years students.
Okay. Now, I've never read any research on that.
Okay.
The medicine has changed a little bit. I mean, there's no real new molecules. I mean, it's still methylphenidate or dexamphetamine. New molecules would be atomoxetine. That's non-addictive. It works on noradrenaline and not on your dopamine. But what you do get is the formulation of the molecules, or of the pill, or the tablets itself, is different. So like for methylphenidate, you get Concerta or Medicanet. Those are longer acting things. So I can imagine that would work better. And what's also changed in the guidelines now is, as you know, ADHD used to be a childhood disorder until about, I think, 2010 even. And now we know it's in adults as well. So now we're changing the treatments. And an important thing is, for example, the drug holidays, which they used to advise, that you treat a patient for school time, and then in holidays they should play and not be on medication. So that's also not accurate, because you also learn by play and you learn by social interaction. So you should actually always have your medication. So I guess the guidelines and the way we treat patients are different. The molecules are not different, really. There's really nothing new, I think, for the last 15 years or so. Atomoxetine is now 12 years old. That's off-label now. But that was the real new molecule, last new molecule. So I think it's more maybe in the way we treat patients that it works better for longer. And it's also important, you raise an important point, is you don't have to treat forever. You don't have to treat forever. You know, you have to reassess patients with ADHD also 6 monthly. And if a patient feels like stopping, then try for a week. I mean, that's a good drug holiday. If somebody really has time and they don't have to perform at work, stop treatment for 2 weeks and see what happens. You know, it's not a life-threatening disorder, so you can stop treatment, see what happens, and maybe it's over. Maybe you've outgrown it. I mean, your frontal lobe still myelinizes until you're 45, so you still get time to grow out of it as well, luckily. And most people do grow. Half people grow out of it anyway, so...
that medication in itself isn't enough, that you need to have parallel to that.
Absolutely.
So maybe that's where the problem lies in terms of that data that I've come across.
Yes, absolutely.
Okay.
Yeah.
Okay, thank you.
Yeah. What's the time? We have 5 more minutes. I'm taking over your role, sorry. Any more questions, comments? Nothing? No, I think... do you have anything else? Shall we break for lunch?
I think it's time to break for lunch. Great. Thank you very much,
Thank you
Constant.
so much for your intervention. Thank you.